Good evening, ladies and gentlemen, colleagues and friends. Thank you for joining me. My name is Ben Lee, and well, it's a slightly different setting that we're meeting this time. Instead of at Noble Biocare's headquarters for our usual study club sessions, well, we're meeting tonight online, and of course that's because of the unprecedented times that we're in. So I hope everybody is staying safe and keeping well. Now, tonight, joining me, I have my colleagues here with me. We have my colleague, Dr. Chou.
Hi, everyone.
And Dr. Agnes.
Hello, everybody.
So together, we are going to be sharing with you on the topic of the management of the wound dentition in a roundtable discussion format. As you can see, we are maintaining social distancing. Now, tonight's session is going to be for approximately 2 hours in duration. So the first about an hour and 45 minutes is going to be on this particular topic. And of course, I'll be answering questions throughout the evening. So please do feel free to send in your questions throughout the evening. And I will be asking these questions to the panel. And I know that many of you have already asked us some questions, some excellent questions which we'll address. Now, for questions that is outside the realm of this topic on the wound dentition, we are going to do a little bit of additional Q&A at the end. So for the ones that's really keen and wanted to stick around, you can join us for a after hours Q&A, so to speak. Now, of course, tonight's session is not possible without the sponsorship of Noble Biocare. They have been sponsoring and supporting me for a long time. So my sincere thanks and appreciation towards Noble Biocare. I understand that there are some new participants too tonight, which are Noble Biocare's customers. Maybe you're joining us for the first time. Then just a little bit about us and who we are. Now, we are a group of prosthodontists that's working out of Chatswood in Sydney, and collectively we work alongside a group of dental specialists, some endos and perios. So we work under a multidisciplinary environment. Now, our practice philosophy is to become your lifelong partner in oral healthcare. Something that we are truly passionate about is to support you, is to help you in whatever shape and form that could be. Now, that could involve in CPD sessions like us, so that we are sharing with you what we have learned as a result of treating your patients. It could be to help out the treatment of your patients, or to simply answer whatever questions that you may have. Sometimes it's got nothing to do with any particular case, but even say, for example, how to manage a patient during the period of COVID-19. Anything, questions that you have, please don't hesitate to just pick up the phone and call us, or to send in an email. We are here to help you and the profession, and we are here to looking forward to work alongside you to manage your patients and to achieve a long-term outcome. Now, of course, coming to tonight's topic of the management of the wound dentition. So take this case here for example. This is a middle-aged patient who I saw some time ago, and he was referred for management of wound teeth. Now, of course, the patient himself wasn't that particular concern. It was primarily by his referring dentist. The patient, of course, noticed that there are some breaking restorations and filling in teeth over the years. So the patient really just wanted a second opinion about what is the status of his teeth and what we're going to do. So of course, we have given him a full diagnosis, discussed all the various different options, as well as no treatment. Now, the patient thought, yes, that's very good, thank you very much. Took that information home and did not return in 5 years. And as you can see, that the extent of the destruction is significant. So so by the time that he came in, then of course, some of those previously discussed treatment options are no longer valid. So the take-home message I have with this particular case is that I think the documentation of what we have discussed with the patient, in particular with no treatment, I think is extremely important, and what could happen if no treatment was being carried out, and really document that. Not only, of course, it is for the patient to know what the potential consequences are, but also for our medical legal protection as well. So, and because of this, that's why I think this particular topic is very important to discuss, the warm dentition, because patients are, with their life expectancy, it is getting longer and longer, and so does the expectation of retaining your own teeth. Yeah. Guys, what do you think about this topic? Why is it important for you?
Well, I think it's a very prevalent topic to discuss because of precisely what you have already identified. Certainly it is a growing concern and growing incidences that we see in our elderly population. People are they're living longer because their dental awareness is much higher now, so they are retaining their teeth for much longer. And if we on average see a 70-year-old patient walking in our door these days, most of the time their well-being is quite fit and their expectancy is rather long, and they would like to enjoy their teeth. But if you have a think about it, by the time you meet a patient who is 70 years of age, their own set of dentition really had already been surfacing in their mouth for a good 60 to 64 years. So it is not unusual that we see what is progressively physiologic wear and tear. Suddenly, as they age, not only are you facing risk factors such as aging, dry mouth situations, the fact that there may be increased parafunctions with polypharmacy, as well as sometimes they might have started to lose some dentition, and therefore more forces on the remaining dentition. And couple that with the fact that after all these years, if they've worn down the enamel, then the exposed dentine, suddenly they meet with a much faster rate of loss if they go and sort of not being maintained on a regular basis. And they could be typically coming, well, I've maintained my lifestyle throughout, and I've noticed mild wear, but suddenly the rate of progression is a lot faster. But equally, it doesn't just hit our elderly population. Because of the contemporary lifestyle, it is an equally prevalent factor for our younger generations with the type of food and beverages that is available to them right now, and a lot of the psychosocial issue that surrounds image. So what do you think, Johnson?
Yeah, this dental damage can be very significant, affecting from one tooth to a full mouth of teeth. Not only is there financial cost involved in terms of the treatment initially, but it's very important to let the patient know it's an ongoing cost as well.
Yes.
I described today is like if you have a heart problem, having stents in your heart doesn't make you having a healthy heart.
No.
You just have to continue fighting with the lifestyle changes and the ongoing maintenance costs as well. There's also the biological cost for a very young patient that we're trying to preserve the tooth structure as opposed to having the treatment that will last the longest, but at the cost of the tooth structure.
Definitely.
Yeah.
Definitely. Now, throughout this evening, we'll be presenting many different cases and all highlighting how we manage these cases. So sometimes you may feel like that every single case of the warm dentition may require sometimes some very extensive treatment. Now, I think that's one point that we want to make, is that that's far from the truth, because the warm dentition can be presented in many different levels of severity. Now, on the left side of the screen, you can see that it's a much younger patient, and on the with very minimal wear, and whereas on the right-hand side, of course, it is a complete different story. So the question for the panel: do we have to treat necessarily every single patient with warm dentition?
I believe that there is a duty of care and expectation that we at least identify what we see Okay, and the level of treatment at the very baseline is to be able to communicate those and certainly put in preventative strategy and to address the significance of the wear. Whether or not that equate to physical treatment or actual restorative treatment, that depends. And I'm hoping that through tonight's cases that we will share with our audiences tonight, that everything tells a story,
Yes.
but whatever we do that we help our patient to equip themselves will help to preserve their teeth for longer
Yes.
and delay any complex treatment and certainly to stage their well-being with their dental health.
Totally.
Yeah, definitely preventive treatment is very important from very young age in order to reduce the damage.
Definitely. The earlier you prevent it, of course, then the lesser there's the long-term replacement and the maintenance cost as well.
Definitely.
So, certainly so. And of course, with the worn dentition, there are many different contributing factors towards this particular problem. It could involve attrition, abrasion, as well as erosion. So what we want to do is to go through this list, and by using cases to highlight the importance of diagnosing each of these different factors. How do we go about treating it, treatment planning, and how do we go about preventing and managing these problems, ongoing problems? And some of the questions we'll be addressing some of these as well throughout the session. So kicking us off from the first factor of attrition, which is teeth-based attrition. And of course, we at the undergrad level, that's been taught very, very extensively or very commonly, which is sleep bruxism. So I think every dentist all knows what that's about, and the construction of occlusal splints to address that issue. But for the problem of daytime bruxism, I think that's potentially an area that hasn't been so widely discussed at the undergrad level. So take this case here, for example. As you can see, this particular patient, this man, he's of course focused on his art, his craft, but as he is focused with work, you can see that his masseter muscle is tensing. They're pulsating with every single cut. Now, of course, if this particular person rocked up at your practice with worn dentition, and if you ask them, Mr. So-and-so, do you think that you notice that you may be clenching or grinding or tensing your jaw during the day when you work? I think the majority of the patient that we see will say, of course I don't. Don't be silly. So I think that's one hurdle that we have as clinicians sometimes, is to inform patients who has been going on their entire lives for decades, but all of a sudden someone they're meeting sometimes for the first time to tell them something that they think that they don't know or they don't have. It's particularly challenging, but that is a very, very common problem. So, well, do you guys see this problem, and how do you go about educating the patients about this phenomenon?
A daytime parafunction habit is actually very common, and I would say predominantly involves a lot of patients that I manage. Yeah. So first, of course, is I ask them to play a bit of detective work to identify, and very often some of them will be able to identify on the spot, but most of them will need to go home and then think about it and then come back to you. Yeah,
absolutely.
And how about you?
I think for patients to be able to agree with you or actually acknowledge, more to say, about daytime clenching habits, first they have to notice. Unless someone is started noticing or know about what to notice, it's very hard to actually gain that sense of awareness. So I think a classic example of if I try to identify some daytime clenches in my day-to-day practice, what I will do is just in the middle of our appointment. So typically the patient would have just come in from the waiting room and we've conducted our examination. I'll give them a mirror. And I'll say, hey, have a look inside your mouth. Can you see the ridging that is on your tongue or the linear alba that is on the cheek? And these are apparent to them. And I would describe them as like pillow marks. You know, when you wake up in the morning and you get that pillow mark on your face. So they have to start to notice And once they're heightened, often, perhaps not the first appointment, but the subsequent appointment, they will be able to come in to feedback more self-discovering information.
Of course.
Yes.
And for the management of this particular phenomenon, I find often we have to teach our patients to have certain cues, certain reminders, because after they have had that such discussion with us, that's all well and good, but how do you remind yourself of that problem? Because nobody's going to, we don't go home with our patients and no one's going to tap them on the shoulder. So often I find certain type of visual cues,
yes.
Something they can feel or something they can see at home, or you can use a variety of different strategies depending on their occupation. So it could be something that they could say wear on their wrist, saying wearing their wristwatch from the dominant hand to the opposing hand, or your loose rubber band, or some sort of post-it note, or a new mug under the TV, whatever that may be, but to be surrounded with some of these visual or tactile cues, so that whenever that thing is bugging them, I think that's a good thing. It's a good thing so that it breaks their concentration, so that now they're focused onto themselves to see whether they are clenching or grinding. And with enough repetition, and I think it's what's being described as cognitive behavioral therapy, which we ripped the page out of the psychologist's textbook. But that is something that's really going to help out our patients at the end of the day. Yeah. What other strategies do you guys have?
Well, I think a further on to the cognitive behavioral therapy is really to teach our patients some mindfulness, because I find everyone is different and everyone's got a different character. But what we are still able to do is just to give them this information. And what I often will do is I'll ask the patient, hey, when you want to remind yourself of something, what do you do? And actually try to get them to then work out the tactics themselves.
Right.
But it is then something I will mark down, because then subsequent appointment, my role is not to be a control freak and be all over them and make them do what I want them to do, but just to check in on them. Hey, last time you mentioned you were going to try to control things this way. How's that going? And that could be very helpful, I find.
How long do you normally see it working out, Johnson?
Usually takes a few weeks to a few months, because it's a bad habit that, even though they know it's damaging their teeth, but they still need a bit of time to break the habit, especially it's stress related.
For sure.
Yeah.
For sure. So here is a case that focusing on teeth-to-teeth attrition. Johnson, could you take us through your particular case?
Yep. I have a middle-aged gentleman complaining of teeth sensitivity, and also severe wear of his upper teeth, the upper anteriors in particular. So if we look from the occlusal view, we can see the severe attrition on his upper anterior teeth. This is due to predominantly daytime parafunction habit, and then partly due to nighttime parafunction habit. Like we have discussed before, often people don't pay attention to the daytime parafunction habit. So we'll kick off with one. He's a fence installer, and when he installs fences, he just basically clench his teeth, and he also loves putting nails in between his teeth. As a holder, to speed up the process.
It's a great third arm.
Yeah, definitely. So I mean, the challenge here, of course, is to control his parafunction. But I mean, lucky he can see the nail is doing a bit of a damage, so he's agreed to not put the nail, in between his teeth. Just put it in between his hands. But we do expect him to continue clench his teeth when he's working. So I mean, we discuss a more short-term restorative material composite to a more indirect approach, and he's chosen a long-term solution. To start off the case, we will do a diagnostic wax-up and increase occlusal vertical dimension. We try to ensure patient is happy with the aesthetics, but also important to let them know the bite is going to be a bit different.
Yes.
Yeah, so very important.
And how did you come up with this diagnostic wax-up?
So most people, they want something, even though they're wearing their teeth, but they want something that looks a bit nice. So it is aesthetic driven as well as getting the right amount of space. So as we can see his pupils there, so we do need to increase minimum of 2 millimeters.
Sure.
So we don't need to cut those teeth further.
Yes.
Yeah.
One question from the audience asks that when opening the vertical dimension, how do we establish that ideal incisal length?
Yeah, incisal length we go from generally the smile line.
Yes.
So, aesthetics. So basically, at rest, generally people show between 1 to 3 millimeters, and then on a full smile, a patient show the teeth length of the teeth should follow the lip, and this is what we generally follow.
Yes.
Yeah.
Of course.
And we try to ensure patients happy prior to proceeding build up in composite. So composite was chosen as my favorite material for the severe attrition cases because it can be used as a core material afterwards. It's a very wear resistant and reduced complication compared to temporary crown and bridge material. We leave the patient minimum of 1 month to ensure they are happy with the aesthetics. They're getting used to the new occlusion. They can perform oral hygiene because we're treating quite a large number of teeth, and then we get the paral function well controlled.
Excellent.
And during this 1 month, commonly we are able to see how the the primary etiologic factor causing the tooth wear, sort of what are their influence and the impact on those provisional restorations. So there is actually really good value to be monitoring these cases during that time.
Another case question coming in: was the bite raised posterior first, or the anterior done first, or all together at the same time?
I would like to do them all at the same time. But if I have to do upper and lower, and there's not a lot of time, for example, a patient can only come in 2-3 hours at a time, then of course I do anteriorly first. Obviously the anterior in this case was more severely worn. Yeah, and patient that like to have a good smile to start with.
Of course. Yeah, absolutely.
Yeah.
Is there a general consensus on how much increase in the OVD is adequate, or how much is too much?
Our patients generally have a good propensity to adapt to increase in OVD right away. Even it's been documented even 3, 5, 6 millimeters.
Yeah.
In majority of a healthy cohort.
Yes.
There are a group of patients who...
My maximum was 10 millimeters.
There are patients, though, there are people who are not so readily accepting changes, and this could be related to personality onwards to medically compromised patients who just have less propensity to adapt.
Yes.
So, we also have to balance on the mindfulness as well as we are increasing patients on the OVD. Of course, it gives us our freedom to redesign the smile and the occlusal scheme. But at the same time, we also have to see how it warrants the interplay of how many restorations are we being involved. And I think as we move on to other cases, there are some very nice choices that you have decided on to be able to showcase and share.
Absolutely.
Yeah.
So in this case, while we wait for osseointegration of implants at site 1, 4 and 2, 4, we waited for 12 months before we convert them to definitive implant crowns and PFM crowns. And because he's a more clincher rather than bruxer, so basically in the 12 months he had minimal wear, so the final crowns sort of resemble the form of the provisionals.
Johnson, one of the questions is asking if some of the posterior teeth was worn near to pulpal exposure, why was it raised 2 millimeters? Was that because so that you can, that was just a thickness for the restorative material?
Yes. So we need to have increase more than sufficient for the material, and hopefully some for the core material. Yeah.
Absolutely. Yeah. So often I find with increasing the vertical dimension, it could be one, aesthetically driven, so that the teeth have to look good at the end. But B is to have sufficient interarch space for your restorative material. And for this particular case, I think was only the management of one particular arch, isn't it? So therefore, you only need to worry about the spacing for one arch, and hence
yes.
that's why it was approximately about 2 millimeters.
Yeah, 2 or 3. Yeah.
Did you need to use a deprogrammer when you were taking the records?
Deprogrammer, I mean, if you, it's very commonly used, especially the American concept. But often in people with really brachyfacial muscles, it's hard to change their habit. Very much. So I personally use the anterior stop to control my vertical dimension to and increase OVD, taking my record there. I do the wax up try-in, so my record is more accurate than as opposed to opening the bite on the articulator. But I personally don't use a deprogrammer.
Yes, I guess there is two different schools of thought. One is to deprogram first, and then recording that neutral position. The other one is simply to say, well, I will respect what anatomy has done, as in the condylar position, particularly for a patient with no TMD and no jaw problems. Well, then I will respect that jaw. Therefore, I will just record that position. And I'll work at that position.
Yes.
Yeah.
And I think there is, I guess I'm just trying to understand the flow of question coming in from our audiences. I think one thing we have to clarify is that for most cases, we do agree that patients can adapt to an increase of OVD. The reasoning behind our use of professional treatment before then is to actually disclose a number of risk factors, whether they are patient aspect that we have to continue to support, or whether it's mechanical issues that we begin to see how our composite resin or our professional restoration speaks to us.
Absolutely.
Looking at the wear and tear, looking at the marginal integrity, look at how those restoration actually last throughout that period, to then enable us to choose and design the occlusal scheme or what material choice we use in the definitive. And as such, that is why I think that we generally may not necessarily do anterior deprogramming, because we are actually respecting the human physiology to adapt. And when we are professionalizing, we're allowing for that period to work itself, for which then we do take into much of those consideration into our final design. Yeah.
Particularly for this case where the patient had a lot of pre-existing dentition to work with, it's very different if the patient had 2 teeth on the top and 3 teeth on the bottom, which aren't even indigitating, then that's a completely different story.
That's
so
right.
I guess these different tools that we have, you just do have to use them accordingly, depending on the case that you have, rather than a one-size-fits-all for every single case that you would treat.
Yes.
So the bite was quite stable. If the bite was what considered unstable, having a couple favorable bite, then that situation would be different.
Definitely.
Yeah.
Was there another question coming in? Was there a temporary splint made during that composite provisional period, and then a definitive splint made at the end?
Yes, for my severe attrition cases, I always make them a temporary occlusal splint, and then make them another one at the end. Yeah.
Yeah.
Not for erosion cases, but definitely for severe attrition cases.
Yeah.
Yep.
Okay.
So now if you look from occlusal point of view, is we expect this patient to continue his habit of daytime clenching. So he has allowed us to put gold occlusal surfaces that is more friendly against the opposing teeth, because we did not restore his opposing teeth. So that reduces the wear, as the gold is one of the more biological compatible material, and also reduces instance of porcelain chipping in this case. But it's very different, because the patient came in complaining of concern about longevity, as opposed to aesthetics.
Yes.
I would not be able to do gold occlusal in that case.
No. It was very, very lucky that he was able to accept that.
Yeah, definitely. And then I have got a 10-year follow-up in this case, and we can see his wound into these gold surfaces.
Amazing.
It's quite considered mild wear due to daytime parafunction. Yeah, hopefully another 10 to go.
Yes, I think it's an excellent choice. especially that it was the management of only one arch. So the gold is very kind to the opposing dentition. And then plus on top of that, your management of parafunction is also in place. So that should be able to provide the patient there, because that's why the case has survived so well. Well, excellent case. Now, sometimes with, of course, dental attrition, things can be worsened by the loss of posterior dentition, then you're resulting in I guess it's so-called loss of posterior support. Now, take this case here, for example, where the patient has lost a significant amount of posterior dentition in quadrant 4, and also the quadrant 3 dental bridge is highly mobile and not doing so well. And of course, needless to say, that's one of the reasons why his anterior bridge is failing as a result of just excessive load. In addition, you can see the shape of the jaw for this particular patient is very square and robust, needless to say. Intraorally, we can see that there is significant overjet and overbite, as well as that loss of that significant inter-arch space. So before that we even can replace some missing teeth, of course we do have to consider increasing the vertical dimension. Now, once we got rid of the failed anterior bridge, you can now just see the true extent and the severity of tooth wear. So after we have used some composite restoration to increase its vertical dimension, you can now see that there is enough interarch space to replace those missing teeth. We've used a number of implant-supported screw-retainer prostheses, as well as tooth-borne crown units to rehabilitate this particular patient. Now, unlike a case where it was pretty much fully dentate, where there's only using, say, one implant or a few implants. Now, in those cases, then the teeth, the natural dentition would take the majority of the load, and the implant prosthesis would be in shim stock clearance. Whereas in this case, there is very little teeth-on-teeth contact. It was pretty much all of it was implant versus teeth contact. So that's why we decided to have a larger number of implants to share the load, and as well as in terms of final occlusal scheme, it was an even bilateral contacts, as opposed to allowing the teeth to take the primary load. And here we have the final centric, which both occlusal planes are much more leveled, and of course I would be silly if I did not try to control the parafunction at the end. And fortunately, this patient was very compliant, both in terms of daytime control and nighttime control. So we'll be seeing him on a yearly basis. And the good news is that it's only the feldspathic porcelain that's becoming from a smooth to a roughened degree. So all we have to do is just polish the porcelain and take it from there.
That's excellent.
Now, of course, attrition is also contributed by teeth versus opposing dental materials. Here is another case that was managed by Dr. Chou. Johnson, would you like to take us through?
Yep. I have a senior gentleman came in complaining of teeth sensitivity and also concerned about the wear of his lower anterior teeth. So the cause of this severe attrition is multifactorial. Once you do wear through the enamel layer, the dentin is quite soft. It's also opposing PFM crowns. There's also reduced posterior support, not many posterior teeth at all. Couple of nocturnal bruxism habit. But also, I mean, when you look at the root stops, I mean, when you look at the chewing pattern of these patients, when you ask them to gently tap together, they never do. They just chop their teeth very hard. Yeah. So I do find that, their chewing pattern has changed as well. And if you look at his preferred chewing side or bruxing side is the left-hand side with a steeper incisal angle as well.
That's the red line there.
With the red line, yes. A diagnostic workshop was built up, and then we built up to the ideal aesthetics in this case. There are two ways to do it. One is we copy the worn incisal angle with a customized incisal table.
In other words, that means to copy what the worn incisal edges look like as part of your wax up and subsequent build up.
Yes, so basically the teeth will be taller but more worn.
Yes.
While this is acceptable for this, senior gentleman, but it's often not acceptable for many other patients.
Sure.
Yeah, they will say to you, I didn't come in for worn teeth to start with. So my preferred way is to wax up into original form, use it as a communication tool.
Yes.
And I'll tell the patient that, your jaw muscle, your jaw function will decide the final form, and then we can copy the final form.
Absolutely.
For this patient. Yeah. And we put while we wait for osseointegration of the posterior implants, and we can see that he's worn his 3-3 back into the original incisal angle, and he's got some mild to moderate wear on the other anterior composite as well.
It really tells a story, isn't it, when you look closely to patients' teeth and restorations.
Absolutely. And to me, it's also a great reminder that we just have to respect what the patient's sometimes physiology is all about. Everyone, they all have a different pattern, and therefore you just have to observe it and sometimes respect that, as opposed to what we feel a nice canine should look like. If you provide that, well, I think your restoration may just chip a lot easier or a lot more frequently.
So this patient was also provided with a temporary splint as well.
Course.
This is due to his more daytime chewing habit, but the composite nowadays are quite resistant to from debonding or chipping.
Yes.
So it's a gradual way.
So one question from our participants, Johnson, is when you decided to carry out the wax up for the patient, how did you go about recording the vertical dimension? Was it in a closed centric position, or was it at the opened OVD?
So we sort of tackled that a little bit in the previous deprogramming question. I like to take the bite exactly on the length I'll be building up the teeth.
In other words, at the opened OVD.
At the open, exactly how I want to open. And that how much to open depending on your experience. You basically want to foresee this will be your build up, and then you take the bite at exactly the position and works up everything according to it. You don't want to open the pin on the articulator because that creates a little bit of inaccuracy.
Absolutely.
Yeah.
And for this case here, another question from our participants: did you build this up freehand, or was this chairside indirect?
Yeah. So this patient was a senior patient, and we know we got to move into indirect restoration. So I use a chair side, but I use a Memoseal putty, a clear bite restriction putty, and then I use a normal composite that I just did everything all at the same time. Yeah.
So you had a wax up beforehand.
I had a wax up.
And then you did a chair side putty. Then you carried out direct composite resin placement.
So I have a chair side putty that covered the lingual, incisal, and buccal. And I put composite into it, a clear putty that I can cure everything all at the same time.
Right. Okay. You mentioned that you waited 9 months.
Yes.
For the provisional phase. Is this something that you would always wait for? What is there a particular formula that you like to use? And what is it that you're looking for during this period of time?
Minimum 1 month, but that's more for erosion cases, mild attrition cases. For the more severe attrition cases, I like to assess the rate of wear, make sure the pair function is well controlled, and ultimately I do want to copy the final form. So if we look at the model on the left that I took when I made the upper temporary splint, we can see the what sort of ideal original incisal table of unworn teeth. But if we look on the right, which is 9 months later, we can see he's flattened his incisors and the canines. So I mean, of course, as a clinician, we like to provide people with something on the left original form, but of course that would lead to increased discomfort because that's not his chewing pattern, and also increased risk of chipping.
Absolutely.
Yeah.
I mean, by applying a greater, a wider incisal or occlusal table, you are certainly reducing the pounds per square inch, so to speak. So you are actually reducing the loading on those teeth, and also reducing the future risk of porcelain chipping.
Yeah, definitely.
And also, actually, it's a great photo that you have on the slide, because as you increase that incisal table for the canines, what it also means, we've outlined already what it means to the tooth and what it means, like, to respect the biology. But what it also means to your crown restoration is that suddenly you are reducing a lot of the resistance form challenges just by having that skating off surface, and also directing the force to a more compressive direction rather than flexural.
For sure.
So that would mean certainly less mechanical challenge on that crown.
And basically, I sent this model on the right to my ceramist to copy the final crowns.
Yes.
Yes.
Yeah, so we can see that the final crown even taken the form of the worn provisional, so to speak. That's a great
thoughtful.
case. Now, moving on to the next contributing factor of abrasion, which by definition, of course, is when teeth is wearing against some other form of a object. Now, I believe Agnes has a case here to show us.
Thank you very much, Ben. You kind of did a big giveaway when we put this slide onto abrasion. It's interesting because we're so it's so easy to assume when we see our patients coming in to see us, and they commonly present with certain problem, and it's very, very easy for us to then make a judgment. So if we look at this particular case example of the initial presentation, it's a 38-year-old male. He's a single father of 4. And he's just coming quite concerned because his front teeth is just getting shorter and shorter. And what is more concerning is that this actually has only been happening in the past 6 years. So that bottom corner there, you see a picture just 6 years ago, and the incisal edge position and the incisal form is pretty much in line with the occlusal plane. So it's not unreasonable for him to become so alarmed. Now, as a dentist, when we first glance at the initial appearance with all that smooth, glossy surface and the fact that the teeth just look like they're melting away, it is very, very easy just to assume I've got an erosion case at hand. And when you look inside the mouth, and certainly you can see the washout appearance, so typical of it as well, that is on the palatal surfaces of the maxillary arch, and somewhat the molars are spared because perhaps they're very close to your parotid ducts. And then in the lower arch, you see more typically only on the occlusal surfaces, whereby compounded with the attrition, you're getting this cupping effect, and you can see the amalgam standing proud there, which is giving you some very, very classical appearance of erosion. And often we will then have a look, and in his occlusion, you can see that because primarily this is an erosional case, attrition level, he is already starting to blunt all those cusps. And you can see some attritional facets going in. But what is the missing puzzle is that anterior open bite. What is actually been melting away those front teeth the way they are? We have to actually, for us to be holistic and comprehensive to identify these risk factors, we should interview our patient and really address to try and identify all the potential causes. So we have to interview them, and in this particular case, we found out that, as he's going through those hard time in his relationship, he's been swishing bourbon and Coke, quite frequently as he is making his joinery. And what makes the appearance of those anterior open bite is that he would swish his bourbon and Coke, keep them in the front of his mouth, and he'll swish them around before he swallow. And then as he then design his joiner work and work with the carpenter pencil, you'll be able to see on the slide here that the carpenter pencil is that flat type of pencil, not your typical one. which at the same time, while his teeth are being vulnerable and undergoing dissolution, he just kept that pencil hold there. So in fact, the teeth surfaces had been wearing down against these lead pencils, but also at the same time, we are able to actually see that if we go back, there is some passive eruption that is also taking place as the tooth structure is lost. So situations like this, after the initial dialogue of addressing the risk factors, we of course then have to move on to the professional diagnostic wax-up, which we will undertake, because this is what I find personally is a good anchor point. So in the diagnostic wax-up, we are able to level his occlusal plane, deliver back the original occlusal form and the dental form, and without pointing out to the patient, I really just will take a step back and let them have a look. And indeed, in this particular case, once we have aligned all the horizontal references, then the patient himself says to me, oh, I am now, something is not quite right. My gum, why do I have more gum on this side than the other side? So not so much we want to identify every single imperfections, but sometimes we do have to give some space and room to see whether these things matter to our patient and allow them a chance to deliver that across. So in this particular case, the diagnostic wax-up and the photo gave him something to look forward to as he worked those, etiologic factor. He has to try and substitute the bourbon and coke. No more bourbon and coke when he makes his joinery. And certainly he's worked out that he'll tuck that pencil behind his ear instead of holding it, in between his teeth.
What is it with you guys treating people always holding things in their teeth? Johnson's got someone in their nails and teeth, and you've got pens and teeth.
Oh dear, I don't know. That's why we're in dentistry, hey? And once we're able to address those issues, we were indeed able to assist him to deliver a final outcome that he really wants and that he could maintain in years to come. So.
Agnes, that's a fantastic case with the aid of crown lengthening. Sometimes, literature suggests that, it takes minimum of 3 months for the gum to be stabilized. And even for some people, it can still continue to change after 12 months. How long do you wait to ensure that the gum is stabilized before you proceed into your definitive crowns?
Yes, I agree. So it can really take 12 to 18 months to mature, and typically we see continued improvement. But minimum, I would wait at least 1 month and at least 3 months if it's thin bowel type, or more. The more the better. This particular case though, after the initial crown lengthening, mainly on the palatal, on the labial areas, we did do some gingivectomy just to please the gingival symmetry. But oftentimes the patient becomes very sensitive because now the root areas is also exposed. This particular patient does live quite far away, so 4 hours drive for him. And in the whole scheme of things, we've mapped out a timeline of management of 9 to 12 months, but only limiting his visit overall to only have 9 to 10 visits, which was great for him. So what we did for him was, after his gingival surgery, we waited 2 to 3 weeks. That was when I saw him, and I gave him his set of professional crowns that I actually permanently cemented them in.
Right.
And then that was maintained in service for 6 months. I gave him a review at a 3-month mark and a 6-month mark to just monitor those signs of stability. And precisely, I wanted to see how those professional crowns were doing, whether they're just wearing in bits and pieces, not wearing at all, or whether in fact there's chipping or debonding. So in this particular case, at about the 7-month mark, we then decided, okay, we're quite happy with the stability of everything. Let's now remove them, and we will now move on to our definitive crowns.
Right.
Very nice.
Now, these questions were asked in regards to the previous case, but I guess the same concept applies for this particular case.
Okay.
So the question I ask is, what happens during that provisional period if you keep on finding that your composites break?
I think that it's important to have this conversation that we do anticipate some wear and tear. And certainly, with these patients coming in, they are of the understanding that if they were to go on this provisional phase, there is a particular reason. And if there is some wear and tear of continual chipping, we just have to continually looking at how we may be able to control those risk factors. One thing they could be more grateful for is that, isn't it wonderful that while things are breaking, it's in composite and it's so repairable. Wouldn't it be a disaster if this is all happening in ceramic?
Of course.
Yes.
Would that make any bearing in terms of changing about your definitive treatment, depending on how often your provisionals break or wear?
Yes, definitely. So I think there are other reasons to consider when you may do a partial restoration as opposed to a full coverage, and these can often be quite aesthetically driven. But the other aspect is, while we are able to embrace to be as conservative as possible and perhaps address dental whitening with whitening products instead of full coverage, the next layer is really these mechanical challenges. So as we observe how our composite wear and tear, it may actually change my decision on perhaps in this particular tooth it's not suitable to have a partial onlay. It may require something with a little bit more resistant retention foam in the restoration itself. That's one example.
Yes. And of course, for this case, you did keep everything at the same vertical dimension.
Yeah, so this case is quite interesting in that he has the anterior open bite. There is a bit of pathological shunting forward as the teeth wear. And if you recall, this particular case did have some occlusal wear on those lower molars. So all I had to do was to guide his jaw back to a slightly more retruded position, and then we were able to have the space required for very simple composite resin restoration on those lower molars, and also inadequate occlusal clearance for occlusal restorative space for our crowns from premolar to premolar. So we did very minimal preparation circumferentially and minimal incisal reductions.
Fantastic. There's another question about, do you prepare the teeth when you tried in your provisionals, or were they just untouched?
Okay, in this case, well, almost all cases we have to try it in untouched, because certainly we don't want to start grinding our patients' teeth down just to do this trying. So, but in this particular case especially, the trying that you saw, the teeth were not touched at all.
No.
So because the teeth had been washed away, they're smaller size than my provisional. And one thing I do love about trying in my diagnostic waxer is that once I try it in it, and as I take them off, you'll be able to actually see how thin the material you're looking at to layer onto the existing tooth. And often it is such good value to then give yourself an assessment of, well, perhaps how much tooth do I need to prepare or not, and what material choices I may therefore have.
Yeah.
Yes.
Great.
Thank you.
And on to the next topic, which is dental erosion. And of course, the erosion could be both from an intrinsic or extrinsic perspective. In terms of intrinsic, and I believe Johnson has a terrific case showcasing us what has happened to this particular lady.
I have this young lady in early 20s, attended an appointment with her mom, complaining about teeth sensitivity, and the localized erosion, moderate level erosion, was due to history of depression and bulimia, as the vomit has a pH of about 3.8. So it's dissolving these teeth. The challenge in this case is the continual management of the mental health issue. So fortunately, she has this under control, which is confirmed with the mom, but it must be re-emphasized that, you know, she must continue to see her clinical psychologist regularly, because it's expected that she will have her ups and downs. So the other challenge is to management of localized anterior wear, because all her posterior teeth are unworn. So treatment options are, of course, we discussed the preventive treatment only, which is increased hydration and also improve remineralization in her case. We talk about management of anterior teeth only, 6 anterior teeth, followed by passive eruption of posterior teeth, or of commonly known as Dahl concept, to restorative management of the full upper arch. But the last option is a bit aggressive. Even if we put some composite resin, we would expect to replace them. And if we do indirect, then there's a lot of ongoing maintenance.
Because there's hardly any damage onto the posterior.
Yeah, from minimal damage, if any damage at all. Yeah. So the challenge in this case is as a result of erosion, she just getting a chipping of her upper incisors, but there's also a passive eruption of the mandibular anterior teeth, resulting in lack of the restorative space. And hence we have to utilize the concept of the Dahl. So we are relying on the body's compensation system of a passive eruption. This is how we end up with a lack of anterior restorative space in the first place. And we are relying to build up the anterior teeth and hoping that the posterior teeth will be erupt in position. Yeah, it is very you have to step out of your comfort zone.
It can be when you do your first case.
Yes.
Yeah, and you'd be wondering, well, are the posteriors going to over-erupt over time? Will they become in contact, and when? And what if they don't become in contact? What do I do then?
I think as clinician, we want so much control into what we offer our patients. Like, I want to know how long things last. I want to know if it works. And suddenly there's this concept here that you want to present to the patient, whereby I don't know if it will work, but if it works, it saves us a lot of other potential treatment cost. And I think that is the most important part of address, because what are the percentages that it may not work?
We'll go through some of the but actually up to 20% will not work. But you know, it's very important to go through patient with some options. So while you present them that, you know, this is another case that I've done, I've built up the anterior teeth. So it's very important to show the patient by putting some composite resin on the anterior teeth to show, well, we can't just restore this front teeth because your back teeth will not touch anymore. So one concept is a Dahl concept, where you allow this back teeth to passive erupt.
Or self-erupt.
Self-erupt, But I will present it in a way that, you know, ideally your case, you know, after we build up your case, if we have orthodontic treatment, that is having the orthodontist putting some braces for you. Now they do straight wire mechanics where they put the braces on the posterior teeth a little bit more gingival, and the wire will straighten to erupt this. I said this is a very controlled manner.
Yes, of course.
But of course it requires a bit of time and treatment, and patient just had Invisalign like 4 years ago. So she wasn't ready to go through the orthodontic option again.
Yes, there's the other option of some orthodontists prefer to use pads.
Yes.
And then elastics to
localized.
Yes.
Very good. And of course, I mean, my least preferred option would be giving them porcelain onlays, given that she is so young. And if we add more teeth, then there's not only its financial cost, but there's also biological cost as well.
And it will be a full arch treatment for her after all.
Essentially, that's what it is.
So a diagnostic workup of the 6 anterior teeth was performed, and as we will be doing this case in composite resin as an erosion case, we don't expect a great occlusal loading. Very different to the patient I've treated with basically, grinding the composite like tofu in 9 months. Well, the worst way cases I've seen, basically. So it's very important to ensure your wax finishing is very smooth, and then also ensure clearance in between interproximal area. So I've done the wax up in this case. So that is for the clinical party to extend into these areas. And so your composite, when you do the build-up, is less likely to stick together. I always do a try-in. So in this case, I try the anteriorly to make sure patient is happy with the aesthetics. Occlusion-wise, as it's very different to our occlusal contact. Only 6 front teeth will be touching. So it's very important to ensure we have even contact on these 6 anterior teeth. I also do a color try-in before this, basically use the composite that I'll be using to put on the teeth, build up as normal, remove at the end of the appointment, and make sure patients happy with the color.
And that's just using a basically temporary crown and bridge material.
In this case, temporary crown and bridge material, and I remove it, and then I'll start my composite build up. And then we have what we hear is a 6-month post-op, and we have the posterior teeth coming together.
Great. So you once you place your provisional, you remove the provisionals, and then you place definitive composite restorations for this particular case.
For this particular case.
Right.
So, but if you have patients who really have high aesthetic expectations that in the first go that the patient didn't clearly outline what they want, then it's safer to do a try-in appointment, and then once they're happy, then you do the build up.
And to this was again one of the earlier questions for one of your cases, but I take the opportunity now to ask that question, which is what technique did you use to build up your composites on the palatal aspect?
So there are different ways that you can approach. You can my previous method with a clear bite restriction material, but my preferred method is the palatal build up in direct chair side. So what I do is I take the model outside the mouth. I take 2 models, one for the diagnostic wax up, and one will be for my indirect shows. So I paint some silicone separator. So these are rubber-based separator on the model, and I build my composite shell on the palatal, and I use this as indirect shows. But because patient has a high aesthetic expectation, so I bonded the palatal shell and I did the buccal freehand. And as you can see in this case, we only build up about 20-30% of the buccal, not a full buccal coverage. So it's very important to do freehand. But if the wear was only mid-palatal that the light can still cure through, then I would use a putty key cover the palatal and incisal, and where the light is still able to cure through.
One question that was asked is, for given this is a young patient and essentially we did increase the occlusal vertical dimension, are we concerned that we're going to give her end up a longer face, as in the extraoral appearance would become compromised as a result of increasing vertical dimension? I thought, well, it's the increasing vertical dimension here is very, very minimal at the anterior level.
This is probably 1.5 millimeters. So not significantly in her case, and plus we always are trying to ensure they are happy with the extraoral appearance as well as intraoral appearance before we try in. I think if we were increasing a lot more, 5 millimeters, then that could be a different story, especially for someone who's a dolichofacial, long face. And then as we're talking about the occlusal re-establishment for the Dahl concept, we have 3 papers from the Eastman Hospital in London. So the mean time will be about 7 months. So, but I always let the patient know it's up to 18 months. And from 0 to 19% of the patient have fail to have posterior teeth erupt in position, but I always let the patient know it's like 20%, so they have a firm idea. Potentially, this can happen.
How often do you find the composites chip during that that increasing vertical dimension phase where the patient is still in posterior open bite?
I find chipping means potentially either they're not complying with the temporary provisional splint we provided, or there's some habit, for example, nail biting. So when they bite into their nail, so the teeth can just bang on top of each other. They create chipping. Rarely do the composite chip. The case we've seen before where it was 9 months is probably as bad as we can see in 9 months. I've 5-10 year reviews, not even half as bad on some of the composite.
Johnson, you mentioned you provide patient awaiting for a Dahl therapy, temporary splint. Can you talk about the splint design, whether it covers the...
it's only anterior only, of course, because we need to wait for posteriority
to allow posterior eruption.
And then I have a follow-up 2 years later, and also another year after this. So she did have a Invisalign 4 years before. So once she finished with me, she went back to her orthodontist to get a full arch, pull down a clear retainer, as her wear was predominantly erosion. We wasn't concerned, and I can see on those retainer there was like minimal wear anyway. But her retainer cracked, so she saw a new dentist down the road who provided her with a temporary partial retainer. And as we can see in the photo, that with the partial retainer in place, the posterior teeth are in contact. So if I take out the partial retainer, now we can see we have a bit of anterior space.
More space.
If you're optimistic, you can always say, show her erode again. Now we don't have to do the Dahl concept.
Always look on the bright side of life.
On the bright side. Now, of course, I mean, we always recommend a full coverage, whether it's orthodontic retainer or occlusal splint for this purpose.
Definitely.
Yeah.
Now, moving forward with erosion. Now, of course, sometimes intrinsic erosion could be worsened by the patient's salivary factors. Agnes, could you take us through how do you go about diagnosing dental erosion, and what do we do to improve our saliva quality?
Certainly, Ben. I think many of us are quite well informed and equipped to talk about erosion with our patient, intrinsic factor, extrinsic factor. But I really would like to highlight tonight that really erosion is a chemical equation. Basically, I've already mentioned before that sound enamel will undergo dissolution at about pH 4.5. And once you wear through that enamel, the dentine will start to dissolve at around pH 5.5. That's hardly by putting anything in your mouth, and the pH might drop. But into this equation, though, the saliva actually plays a very important factor. So I'd like you to, really highlight here that there are times where I still would take out the saliva test to show my patient, this is a legitimate concern, that there are reasons why we develop these tests for use, and it's mainly a communication tool. But as we explore the saliva component, I really would like to highlight there are 3 ways that I would always inform my patient about just having a nice quality and quantity of saliva and a healthy mouth, what it does to preserve our own natural teeth, and what it does and what it means to our restorations as well. So my 3 key goals in communicating to patients is, number 1 is they have to have good hydration. And a simple test that we can do is by everting the lower lip of our patient and dry it with some gauze, and just watch how long it takes for there to be some saliva to bubble up on that lower lip. Ideally, it should be less than 30 seconds, but between 30 to 60, it's reasonable. But having good hydration with drinking at least 2 liters of water a day would be the main goal. Aside from that, also look at how frequent our patient drink alcohol or coffee and tea, which are diuretics. So they're actually depleting their hydration even though they are having a drink intake. On top of that, depending on their medical presentations or whatnot, pilocarpine could be of use. This could be available in the form of tablets or lollipop, which, you know, the jaw function can stimulate more saliva. Yeah. And of course, we have our biotin support in our industry for dry mouth. The next thing I really would look into, and this gives me a safety blanket because this is something I would share with you all for managing my patients with acid erosion, is bicarbonate mouthwash. Okay, so in that slide you saw before, water is still a very good strong. Yes, you can recommend for people to use sugar-free pastels, lollies to chew after a mealtime. But when you are actually uncertain whether it's intrinsic or extrinsic acid, whether this is regurgitation from a lack of a mealtime, whether, you know, when you're actually uncertain, having the bicarb mouthwash just 3 times a day will help, you know, chemically buffer that acid for you. And I have found that that is working very well. And so that was very helpful. And of course, the last armamentarium is to ensure that the substrate, which is our teeth, are well mineralized, and that this is by means of using Nutrifluor products to remineralize our dentition. But what I also really like is the tooth mousse. To really help to improve the mineral content and the enamel prior to us considering any bonding restoration.
And is there any your favorite product in there, and do you use a carrier to?
Yeah, so since I do recommend a bicarb mouthwash, I don't want to complicate the equation much unless by preference the patient just really like mouthwash in general. I do like to ask them to brush with the tooth mousse, not as a cleansing agent, so they would brush with their normal toothpaste of their liking. And then at the end of that, before bedtime, they get another toothbrush that is separate only for tooth mousse, and they'll just brush all over their teeth and then keep that solution in their mouth to rinse for another minute before spitting out and then going to sleep is my preference. Yeah.
Terrific.
If they already have an existing carrier of, like, you know, a bleaching tray or a splint, they can for sure use that. So as a lead-in to the next case is a patient presenting with a Sjögren's syndrome. She came to see me in her 40s already. So this is a condition that she was born with. So in her younger years, she did face a lot of caries scenarios, not exactly to her own doing, but really in a dry mouth, there's a lot more risk factor for decay. By the time she saw me, the caries risk is largely controlled, but the composite resin had been in there for about 5 to 6 years, and it's now showing a lot of degradation of the margins, and there are signs of on and off potential caries risk still underlying. Not rampant decay of any sort, but certainly when we look inside her mouth, you can see that even without any cotton roll or salivary ejector, like, it's very dry. And what's more interesting is when we look at the attritional facets that are there, so you can see that how the enamel's worn through, and we begin to see a bit of dentine cupping. They also line up with a lot of the marginal degradation of the composite. So indicating that, you know, this dry mouth condition is really affected the bond. And as the teeth undergoing function and the flexing of the material, you can actually see those wear and tear. Her primary concern to come and see us is to improve the dental form. We had a discussion about our choice of material, and obviously the market is quite commonly we still have our composite resin versus our ceramic. And after our lengthy discussion, and even though she's in her 40s, she is a very wise lady, and she's heard of all the different reasons before, and she seemed mindful of it. But we still feel that there are some underlying risk factor. So for the sake of repairability and and affordability, etc., we chose to help her do her next rehab in composite resin as well. And the good news is 1 year on, this is my follow-up with her as she walked into the clinic before any hygiene or any surfacing. We are able to actually look at those surfaces and think, we may be changing something in the environment now, because we still have that luster, and just in those lower dentition, we're beginning to see some saliva rehydration. And the main thing is the patient feedback herself, that her general well-being, the wetness in her mouth, she's finding that she's more on top of things and more mindful. And she really reported that the bicarb mouthwash was very helpful for her and made a bit of a difference.
To me, that case was just a showcase of that technical excellence is of course important, but perhaps even more important is the management of that oral condition.
But I think sometimes, I don't feel that the dental excellence is any different to any of my other colleagues who have placed the work. I think the main difference he really highlights is how your workmanship can lies within the patient who carries your work from a day to day. And in this particular, we were quite fortunate that she found a tactic that suited her. Mm-hmm. So she was right in all the information had been relayed to her. I have told her nothing new, but in our dialogue, what we were able to do was she was able to also work out a strategy that works for her. And hopefully now we have the tactics, and we're going to move on to building some healthy habits.
Yes.
So,
and I guess that the point that I guess you made, I guess, could be interpreted as it's really important for the patients to take the ownership on board, the fact that whether it's parafunction, whether it's acid erosion, whether it's abrasion, that they have to take on board that responsibility and owning that problem, and to work with us to achieve a successful outcome. Yes. Dental rehabilitation isn't something that we whack on the strongest material known to man, and then all of a sudden, ta-da, everything's just tend to last forever.
No, it takes two to dance.
It does, it certainly does. There was many questions actually previously about what happens when all the provisionals fail. Do you ever abort the definitive treatment phase because your provisional just didn't work out? Basically questions along that trend of thought is the worst case scenario. And I guess my thought process is that patient selection process is extremely important. I mean, you see us doing a lot of management here. It may seem like that we are treating every single patient that walking through the door with these sort of treatments, but I think that's actually, again, far from the case. The way that I select patient, in the past, I used to think that a compliant patient is a good patient. And a compliant patient means someone that just simply does whatever I ask my patients to do, whether it's just to brush their teeth 3 times a day or to wear their occlusal splint. But I find with management of these types of patients where there is so much dental problems, it takes a slightly different mindset that they have to acknowledge and to own that problem and to work with us. And they have to be rational people. They have to be sensible people. They have to have some level of common sense before you can say, you know what, I'm going to have a go at this, because so many things can go wrong that during this really lengthy treatment. I mean, Agnes, previous, you said one of your cases only took 9 to 10 visits. You know what I mean? That's a large number of appointments for our general dental colleagues out there that's listening tonight. Being only 10, like what's your average number of appointments then? If it's that one only took 10, so it does take a tremendous amount of time from the patient's behalf, from our behalf, a lot of financial costs. So this is something that it's executed with a lot of thought, a lot of planning, a lot of discussion in place to get there at the end.
Certainly.
And coming to the next and the final contributing factor of external extrinsic erosion. Of course, this is could be by some sort of food or drink and beverages. This is the patient that I saw some years ago who was presented because the referring dentist found that her anterior composite keep on falling out, and the patient's concern was that some of her teeth are becoming thin, and she's worried that they may chip. And of course, I did not know the true extent of the erosion until I segmentically removed the pre-existing composite buildup, and until I removed it, then I realized how bad things were. You can see the classical erosion pattern of these dentine cupping. So what has happened here is that this particular patient loves eating lemons. Now she simply cuts up lemons into wedges, like an orange wedge, and this patient would put the lemon wedges between her teeth, and she would suck onto it and to eat the lemon like she would eat an orange. And of course, that's those very acidic lemon juice, over decades of daily occurrence. I think she said something like 3 lemons a day or something keeps the doctor away. So that certainly has done the damage. And I think the reason why the composite keep on falling out was because the teeth were so hypomineralized. So it's like trying to composite bond onto a hypoplastic, like a 6-year-old molar or any hypoplastic teeth. You find that your composite bond, it just doesn't work very well. Yeah. And so same as this situation here. So the first thing we had to do was to remineralize these teeth to make sure that the surface that we try to bond to is normalized again. And again, that could be done using tooth mousse or Nutriflora 5000, and of course addressing the patient's dietary habits. So instead of eating them like oranges, you can recommend her to perhaps potentially put it into a juice form and drink, or using a straw or something like that. So once that has been done, then the rest I felt it was just a technical exercise. So in this case, I placed composite restorations on the incisors. I did give her PFM crowns for the canines, and that will provide her with canine guidance. We did increase the vertical dimension slightly too, so we provide her with some ceramic onlays for the premolars, and also a couple of full gold occlusal stops for the 6s. And 7s.
Ben, I think one thing that our audience really would like to know is when you roll out some strategic crowns to protect your otherwise direct restorations. And there are many reasons why we may choose to roll things out in stages. What is your preference? Do you actually have a default that you go to of what strategic crowns to place first?
Right.
Or is there a segment that you will look after first prior to the other?
Right.
Would you have a personal preference?
Right. A lot of questions there.
Well, one of
our prosthodontists who is actually viewing tonight asked a question from UK who said that, do you always use
have telepath.
Yes, that's right. That's right. Do we always use the PAP approach? So for the audience who's not sure what on earth that we're talking about, is there's a sequence in full mouth rehabilitation. What do you treat first definitively? Do you go to the anterior first? Then you go towards the posterior, so that the benefit there is that the anterior is the aesthetics that sets the stage, and then of course everything else would follow. Or do you actually treat posterior first to stabilize your posterior occlusion, then finishing the anterior? I think it really depends on the patient. So while both of these strategies will work, I think if a patient, sometimes you can argue that, well, of course doing posteriors from a technical standpoint might be better because that's more stable in the long run. But sometimes patient has a limited budget. They may say, look, I can only afford these number of crowns for the foreseeable future. I've been laid off the job because of COVID-19, and I just can't afford a full mouth rehabilitation. So you then have to, I guess, diversify that limited budget that the patient has towards what matters the most. So for this particular case here, this was primarily an erosion case. So therefore, and you can see that from some of the previous photos that parafunction really isn't the problem. I mean, if she had significant parafunction, those teeth would have been just melted like there was no tomorrow. So I wasn't too concerned about the factor of dental parafunction. On top of that, she has excellent oral hygiene, a very compliant patient. So therefore, I was comfortable to provide the minimum number of indirect units at the canine level, which is at the corner of the arch to provide canine guidance, and then at the sevens to have a better occlusal stop. So that was the decision-making process, and of course, keeping the cost down for the patient.
Fantastic.
There's other cases could be much more aggressive. So this is a case which involved both chronic alcoholism as well as dental parafunction. So this took decades until the patient arrived at the door, where his referring dentist did a terrific job placing a lot of these composite restorative, they're almost like composite crowns, and that's what's been chipping over the years as a result of A, the substrate is somewhat hypomineralized, and B, that there is significant dental parafunction. So our dental colleague has been maintaining his teeth as much as possible at the status quo level, and it took him until that he has had a stabilized psychological, I guess, status with his counselor, that now he feels that he is ready to proceed with definitive restoration. So not only he wants to improve his self-esteem by improving his aesthetic appearance, B, he really wants to start to land in some jobs. So he wants to attend his job interviews much better presented, and as well of course protecting his remaining dentition. He also has a limited budget. He said, look, I can only afford the upper arch at the moment. So we had to, of course, stage that treatment over a number of years. So for this particular case, we did an extraoral wax up first, then transfer that information using ProTemp into his mouth. There was another question from the audience earlier about, well, how do we remove a ProTemp material? Assuming that you're not bonding ProTemp to the teeth, you're just doing a mock-up. Does it lock into the teeth very much? My answer to that is that it depends on how long you wait before you take things out. And then the other trick to have is you can put in a roll-up orthodontic wax. If the patient has a lot of interdental black triangles, you can just insert that a minute amount of orthodontic wax in between the teeth. And then when you introduce the ProTemp into the mouth as a try before you buy concept, then it's much easier to remove at the end of the day.
Yeah, I find one mindful thing you can do is you can ensure that your diagnostic wax-up model is very well defined. So you have very nice and clear interdental space, either from your original impression model form or during the wax-up process, because only then you will be able to do a putty key that is very well adapted, and when you insert it in the patient's mouth with firm pressure, you will be able to ensure that you don't have extra bulk or the locking in.
Yeah, absolutely.
Yeah, with the undercut, I mean, works is a great way, but in expensive way would be using some light body PBS squeeze into the undercut. So basically,
Another good trick. Trick to have, yes. So once the provisional stage, I think for this one, I think I waited about 2 months so that he is he's feeling comfortable phonetically, occlusally, and jaw-wise. And then we, of course, again, it's just a technical exercise of replacing the provisionals into definitives. So here we decided to use the PFM crowns, all of which had actually 360-degree gold margins to maximize the marginal adaptation. and having metal occlusal surfaces for a lot of the posteriors. My biggest concern for this case is that patient says that he's going to come back later on to have his mandibular arch done, and we all have patients like that, but we just don't know when they're going to come back. So I'm always worried about wear of porcelain against teeth that's already down to dentine.
Definitely.
So I provide this patient with a mandibular, actually a full arch occlusal splint for its protection. Ladies and gentlemen, thank you so much for your questions this evening. Keep them coming. We've been flooding with questions, and my apologies in advance that we simply could not answer every single question that there is, because there has been just simply far too many. And but nevertheless, we deeply appreciate all the questions, and we'll try our very best to go through them as many as possible. So now that we have already covered a large number of the contributing factors towards the wound dentition, so maybe we can wrap things up together. So where do I start when a patient rocks up to your practice with wound dentition? Because people treatment plan often in different sequences. Where do you guys start?
I think diagnosis of the etiology is a very important, having a preventive strategy, but also that matches with a patient's expectation as well.
I find when I meet my patient or receive a referral, I will still have a look at what is the presenting complaint and what are the goals that the patient wants. Sometimes it could be related to tooth wear, but sometimes a lot of the times the tooth wear concern is secondary. But what it really brings out is, in many of those cases, when we actually then look at the reality of the situation, we will then be able to truly see how much significant component is this tooth wear in the whole scheme of things. And from there, of course, then we work out the etiology and work out different ways. And but no matter what we do, though, I think being able to control those background risk factors and to take the elements to consider the mechanics of how we're going to deliver those restoration in an aesthetic way, it's important. But I suppose then being able to map out a maintenance regime and any complications, expectations, and management associated or anticipated, it's only a new chapter of what they have.
Absolutely.
Moving forward.
So there are some articles that's being published in the dental journal. This one here by Turner, that was published in 1984, and this one looks at the occlusal vertical dimension, or OVD, as the guideline, and they separated all the different cases into whether there's wear with loss of vertical dimension or wear without loss of a vertical dimension. Now you may ask, well, how can you get wear without loss of OVD? Well, that's because of compensatory over eruption over time. So although this is one of the landmark articles, but however, it's still quite limited, because the only factor really they're looking at is occlusal vertical dimension. So the next article here is published by the American College of Prosthodontics in 2004. And of course, this is looking at all the cases based on case complexity. So this one is a little bit more comprehensive than before. It not only looking at OVD, but also looking at how many teeth were affected, in how many sextants, and what is the severity. So what we want to do now is to go through some of the different cases and to highlight, well, how do we go about managing these different cases? But of course, with every, sorry, Agnes, you go.
It's challenging though, because although the classification we will take our audience through already try to look at the occlusal factors, but what it doesn't really highlight is some of the aesthetic concern that is very real as our patient walking to us. So I think on top of that, as we take you through the classification, we will try to input as much of how aesthetic influence our decision making into it as much as possible.
Absolutely, because a lot of our patients that's coming to us today, their main concern sometimes is not about wear, sometimes and a lot of times is about aesthetic appearance. So Exactly. So therefore, a lot of our treatment plan has to start off with the smile. So, and for example, with the photos here, on the left-hand side, you have a patient with a low smile line. Well, of course, in this case, you can probably increase the occlusal vertical dimensions by making those teeth longer. Whereas the one on the right-hand side, although it's also a case with worn dentition, but that already have an excessive high smile line. So if you were to increase the vertical dimension even further, well, then aesthetically, that just may not look so good anymore. So you're absolutely right, Agnes. There are a lot of our treatment planning it's not driven by one article or one dogma. There is actually a variety of different factors that we have to consider.
But they do certainly at least help us sieve the content.
Definitely.
Let's share the cases.
So, according to American College of Prosthodontics, the class 1 case is defined as something that has only affected less than 3 teeth in one sextant that has very minimal or no disruption to the occlusion. So, in other words, it's like an anterior localized wear case, or what could be a posterior localized wear. Johnson, you have a fantastic case to walk us through.
Yeah, so I have this young man complaining of repeated chipping of his composite, and also unhappy with the worn appearance of his 1-1 and 2-1. So the challenge here is always to get the patient to recognize that they are grinding their teeth. From our perspective, worn teeth equals nocturnal bruxism or parafunction of some kind anyway. But from the patient point of view, it never comes across as that. They often will describe, well, I chipped my teeth when I was playing sports or biting a fork or glass, and I went to my dentist and my dentist repaired it. Or some may even say, oh, my dentist shortened my chip a little bit to make it a little bit smooth. So then I started telling the patient, as dentists, we are very precise, but we are not milling machines. You're trying to cut 2 pieces of paper like jigsaw puzzle, and it's very difficult to fit together. And they ask them, say, well, let's move your jaw around and we'll see if they match. If they match perfectly like jigsaw puzzle, it's most likely you are grinding their teeth. So in this case, I started with protrusion. You can see 1-1 fitted perfectly and part of 2-1 as well. And the other thing he was unhappy with is with the length of his teeth as well, how it's worn. So one way to confirm what length he would prefer is to put a bit of a composite mock-up.
Sure.
The direct composite mock-up doesn't even require wax up. And then we check lateral excursion. You can see he's basically good function. From central to second molar. But what we can see in the 2-1, if we were going to increase the length in this case, he will basically chip it the next day.
Yes, well, that's why that distal corner is much shorter, isn't it? It's because of that particular pattern of attrition.
And now the patient understands, well, any bruxers will have 30% more increase in chance of complication, and hence the more importance of wearing an occlusal splint as well. Yeah. So the next step is to confirm the aesthetics. So since his main complaint was unhappy with the worn teeth, accept the current length was not an option for him. We went through the next option of orthodontic intrusion of the lower incisors, followed by increasing length of the 1-1 and 2-1. Often I find unless the teeth are crowded, or we need to improve it in bite, rarely do patients want to go through the cost and the time and the lifetime retention of orthodontic treatment. So this option was rejected. We went through the third option of taking out a burr and then take about 0.5 millimeter of enamel off, and potentially a little bit more in the 2-3-2, and followed by increasing length of the upper teeth, which is the option that he chose. Yeah. And we are placed to Emax veneer in his case, and then of course the idea is to preserve as much enamel as possible to maximize bonding and getting him to wear an occlusal splint.
Absolutely.
Yeah.
That is beautiful.
And
there's actually a lot of thoughtfulness, because I believe you've maintained his grip function
yes, of
from
course.
1-1 to 2-7 as well on those veneers.
Yes.
Johnson, would you ever consider crowning these teeth? Because often a lot of our colleagues would feel uneasy about placing veneers on a bruxer, so to speak. So what are your thoughts with that?
So because patient is only in the mid-20s,
Yes.
so of course we have to be more mindful about while a crown will have a more longevity and less complication, less frequent of debonding compared to veneers. But ultimately, if we put a crown at 25, well, the tooth, while the crown will last, but the tooth underneath may not last until his lifetime. So we understand we do veneers with a view to change to crowns when he is a bit older, and accept the increased rate of complication, debonding, but more preservation of the tooth structure. Yeah.
So in other words, that this decision was because of biological conservation instead of technical longevity.
Longevity, yes.
Yeah. Okay. Terrific.
Yeah.
Great case.
Great. Thank you.
Moving forward to what's called as Class 2. This is where slightly more number of teeth are involved now. It's more than 4 teeth, but restricted to up to 2 sextants. The occlusal scheme is somewhat compromised. So often in these cases, what you typically find is that, say for your anterior erosion type of cases, from say canine to canine, something like that, where the treatment of the Dahl concept again really comes in for a lot of these cases. Agnes, you have one of these cases.
Yeah, so this case that I'm about to share with you all is a 14-year-old boy with hypodontia, and the only remaining permanent dentition that he has are his upper 2 centrals, the first premolar, as well as the first and second molars. So the way that the anterior deciduous dentition have worn away does make this case scenario fit into like a class 2, perhaps edging on the class 3. But this is also a great case to demonstrate how by utilizing the Dahl principle, we're able to apply a simple concept and convert an otherwise seemingly complicated case to a more easier managed one. So his primary concern is obviously some of the aesthetic issue, because he still have to wait until he's 21 to 23 before he's into that zone to look at definitive replacement of these deciduous teeth. And he is quite a big boy as well, so he'd love to actually have some matching size dentition to those central incisors. So what we're able to do for him is that when he first presented to us, he had just completed some excellent orthodontic work, which allowed the first and second molars to be in a class 1 relationship. But it leaves us no restorative space at all to help him transform those deciduous dentition. So what we decided to do was to increase his occlusal vertical dimension and build up those dentition from what now looks like 1-3 all the way to 2-3. It's quite a big challenge on those baby teeth, but it is quite surprising that this composite link on rebond has really surfaced and lasted 6 years. And we did see over the first year that those molars have come into contact. And what it allows us to do is, if we look back onto the slide, is that as he ages well, the composite only had very minimal wear and tear, which we polished up. But as he reached into his adulthood, we're also able to conveniently re-veneer the tooth form to match his facial shape. So as you can see here, he has grown from a 14-year-old to a 6'4" Hagrid that we are able to reface those veneers for him. And now, because he really accept and like the dental proportions, it also makes the future replacement of those deciduous dentition much simpler because the teeth are already in the right place.
Yes. One question from the audience asked that, do you have a favorite composite? Any particular type of, whether it's nanofill or microfill?
I do commonly use Filtex Supreme. Yes.
For that case, did you give him composite canine guidance?
Yes. And those composite were, so from 3 to 3 was linked on a rebond. And he has been prescribed an occlusal splint, which is compliant to some degree, but as he grows, it no longer fits him. So I have to keep servicing him. I think over the past 6 years, I've provided him with 3 changes of splint.
Wow.
So reasonable, every 2 years or so. And he's actually a video gamer, so he has his daytime clenching activity where he just sits there and play his game.
Right.
So definitely, but he is very mindful and very good with wearing his splint.
Yeah, wonderful. Now with using composites, a lot of the questions from the audience also ask, can you use flowable composites? So here's one of those such cases. Now this is a dentist, a dental colleague of ours. She's in her 30s. She's been suffering from reflux her entire life. Now, her mother is actually also a dentist who has been looking after her dental needs over the years. And now that she's at this particular age group, her mother said to her, "I no longer want to be your dentist." So you can go to someone else and pay for your dental treatment. Thank you very much. So now, being a dental colleague of ours, she already has a treatment plan in mind. So she understands that concept, that Dahl concept. So she brought the treatment plan with her, which essentially is, can you please build up from canine to canine? And I'm of course aware there's going to be posterior eruption and so on and so on. So as you can see intraorally, that there is erosive wear from canine to canine. And we simply provided her with composite wax up, and then subsequently the lab has duplicated the model and made us a clear suck down using a clear PVS material. They also drilled some holes into it, 2 holes per palatal surface. So 1 hole is for the insertion of the flowable composite tip, and the other is it's like a vent for the excess material to flow through to help to reduce the amount of excess. Picking the shade, there was a couple of audience asking, what are your steps for taking a shade? There's many different ways of doing it, and this is one of the many, which is you just put a small blob of the composite that you want to use on the buccal aspect without any bonding, of course, and you just cure that. And so very quickly you would find out, well, what perhaps shade will work better. In terms of treatment, we simply just removed her pre-existing composites that were there, sandblasted the teeth, and then we, by using essentially plumber's tape, we have isolated every second tooth that you're about to bond to, and then with the exposed dentition, you just etch and prime and bond as you normally would, insert your stent, and then inject your flowable composite. And cure through the stent. Once it's cured through, you do take the stent off and then continue curing to make sure the composite is fully cured. And here you have some excess, and it doesn't take too long to cut it off because what's underneath the every second tooth is plumber's tape. And that's what that looks like. So now you have the other every second tooth to worry about. So again, you repeat the process. Isolate the 3 teeth that you just finished, and you etch, prime, bond the remaining 3 teeth, and finish. So overall, I think it took me about an hour and a half for 6 teeth under this very controlled manner. So of course the patient understands that there is this posterior open contact, as you can see, which I think she reported that everything closed by about sort of 6-7 months from this point forward. She came back at the 3 months level. This was the post-op shot. So you can see that the composite is holding up fairly well during this period of time.
And flowable is not flowable, isn't it? Because improvement in flowable technology with the monomers, they can put more fillers in.
Yes, a lot of flowable composites these days have a significant amount of fillers, somewhat, I think it's up to even 75% of the fillers. This one is from a Carrari Majesty. So one of their composites certainly has a lot of these fillers inside. So in her case, that you can see that her level of parafunction isn't something that is significant. It's primarily erosion. So therefore, I felt comfortable using flowable composite for this particular case. Now, if this was a severe bruxa, I probably may not be as confident to say that this can work well in the long run.
Yeah, me too.
Moving on to class 3. This is where now significantly more number of teeth are involved, which is minimum more than 4 teeth in up to 5 sections. So that's not too far from the whole mouth, and with significantly compromised in the occlusion. This patient here is presented because he felt that his teeth are getting too short and he would like to improve his aesthetics. He's in his mid-age, he has a very stressful job, but he just wanted to present better in front of his peers and also just to feel better. Intraorally, you can see that the majority of the erosion and attrition is concentrated in the anterior aspect, but so are some other number of posterior teeth. Similar picture for the bottom jaw. Occlusally, he has significant overjet and overbite. So the patient himself actually said that he wanted to improve his extraoral appearance. So that wasn't something that was our driven criteria. There were a large number of options covered. Firstly, no treatment is preventative only is always given as an option, but of course that does not address the patient's concern of aesthetics. Secondly, you could attempt to just restore the 4 teeth, which is, in other words, just purely addressing the patient's aesthetic concern without improving the occlusion or having the ability to improve his extraoral appearance. But often with that second option, it could involve significantly more tooth reduction to provide an indirect restoration, which I was not feeling very comfortable at. Option number 3 essentially is a Dahl concept, which we would increase the vertical dimension, only working on the anterior teeth, allowing posterior over eruption, which would address his aesthetic concern. However, we cannot improve his occlusion, at least from his external appearance. Option number 4 includes the management of the entire maxillary arch. Here is, I guess it's a little bit quicker, certainly address the aesthetics, but also cannot address his secondary concern, which is the extraoral appearance. But option number 5, now it's something different, which is we're going to carry out pre-restorative orthodontics, plus or minus some sort of form of orthognathic surgery to really change the landmark, and then you can restore the teeth, and also with a much less number of teeth that needs to be restored. And the last option of extraction with implant replacement, that was actually proposed by the patient himself. Often, right?
What extreme measure.
It is. We always get patient that comes in going, am I a candidate for an all-on 4 or something like that? And sometimes we just cringe. But so obviously the patient asked a question here, again, well, that all these options sounds very drastic, so very lengthy. Can't you just take some teeth out and give me some implants instead? Which in this case I felt was just a little bit too aggressive for my liking. So it was option number 5 that the patient decided to go with, which is orthodontics first, then restoration. So with the orthodontist, we did a digital mock-up. This was actually the second mock-up that we agreed on. So as you can see that the teeth, not only we had enough vertical clearance, but also there is a horizontal clearance, which means that at the end of the orthodontic treatment, we can simply add restorative material to these teeth instead of needing to prep it any further. So this is the initial band up using lingual braces incognito, and then leveling. And this was immediately after bilateral sagittal split, so to advance his mandible. And this was the final occlusion after orthodontic treatment. The anterior composites place was just used as a provisional material to give the oromaxillofacial surgeon some landmark during the mandibular protrusion procedure, and also to improve the aesthetics temporarily. So by the time the patient came back to me, in terms of restorative work, it was actually very minimal. All I had to do was to just simply touch up the enamel margin, make sure that the final restoration has a good landmark to be bonded to. In terms of the buccal, we did not prep it fully. You can see that it's just a bevel in the incisal edge by about 2 millimeters or something close to that, just so that the ceramics can have a chameleon effect. This was the final ceramic material. As you can see that from the buccal aspect, the ceramics are very, very thin. And this is the palatal view. So I'll just go back. This was the buccal view. You can see how thin the ceramic is, and the palatal view. So this was lithium disilicate. Emax restorations, and that was just simply bonded on. So overall, there were a very minimal restorative treatment, but the overall treatment plan took a long time, and the orthodontic and the surgical process was quite long. But the part of my job sometimes as a prosthodontist, I felt that if I can manage the case with the least number of restorative units, I think that is much better, because there's lesser restorative costs and there's lesser maintenance in the long haul, as opposed to find the most complex restorative treatment plan with the most number of units.
And I think it's a great case as one of our wrap-up cases this evening, because in essence, the patient came in and he even had a drastic option, thinking in his mind that he was to take the 2 front teeth out to have dental implants in place. And yet once he has been informed of the range of surfaces and all the multidisciplinary action and how it may address his growing up concerns of his profile, etc., that he did actually receive quite a comprehensive treatment overall, but the prosthodontic element could be so minimal and could be so conservative. And it is quite amazing how you would attempt that labial chameleon border. It's beautifully executed. I think, I'm in awe of how much work that's gone into there. And it's quite nice for a case where there is, there's actually quite nice that the patient also had a relatively low lip line. But I just think that is such a nice treatment. And it's amazing how people make decisions once they feel informed.
It's a fantastic case, but it requires a lot of collaboration with your orthodontist.
Yes, absolutely.
With a digital mock-up, you were saying twice, or the photos in between, and then coming back for you to check before final debanding, and also collaboration with your, with your ceramist. A lot of general dentists complain when they send their patient to the orthodontist, don't see them until after debanding.
Yes.
Any tips, to improve this relationship?
Yeah, only recently I had a patient who was referred, I think she was in her early 20s, that after her 3rd round of orthodontics, it was debanded. She landed in the chair for the management of congenital missing lateral incisors, and she was informed that just go to Ben and he will give you some implants. And of course, after taking a CBCT scan, and I find that in one side the roots were convergent.
Oh, wow.
And on the other side, there was significant hard tissue loss, which quite extensive grafting is required. So unfortunately, I have to deliver the bad news to the patient that this isn't going to be something that's so straightforward. I can't just put 2 implants in, so to speak. This unfortunately needs more modification before you can have implants. So of course, the patient was devastated after the 3rd round of orthodontics. So you're right, Johnson. We all have had those cases before. Ultimately, you do have to find like-minded people to work with. So with the orthodontists that I have been working with, we've been having the relationship over a decade long. And I give him a very detailed prescription, orthodontic prescription. It's certainly not please manage orthodontically as you see fit. It's a very long checklist by objective parameters.
Yeah.
You know, I need this tooth to be up by how many millimeters, and that means how millimeter palatally clearance, etc., etc., etc.
That's why you objected the first digital plane.
Yeah. So sometimes I feel sorry that for the orthodontist that I work with, because there's so much things for them to think about during the planning. And of course, orthodontically, your teeth don't always move where you want them to.
No.
There's a lot of detailing involved. So to get there, to make sure the final result does match all the bullet points that I put through, I sincerely thank the colleagues that's putting through with me over the years. And of course, from and the extraoral appearance that you can see, without the mandibular advancement surgery, there's no way you can achieve that sort of extraoral appearance. So the last classification, and the most complex of them all, this is where practically, all teeth are involved, severely compromised, and also the occlusal scheme is severely compromised. So Johnson, take us through this very challenging case of yours.
Yep, I've got a middle-aged gentleman complaining of teeth sensitivity, but also concerned about the worn appearance of his teeth. So basically, with all the classification, we're talking about appearance, isn't it? It's no longer concerned about the longevity of the teeth, where we can just put gold occlusals anymore.
Yes.
So when they're concerned about the appearance of their teeth, means they have very high aesthetic expectations. The challenge, of course, is the aesthetic expectation. Secondly, as a dentist, we like to be conservative. We like to preserve tooth structure, but often they don't come hand in hand in this kind of cases. So if we look at the view, if we look at the upper anterior, you can see what we call a very severe attrition of a more like a knife, almost like the scrap by knife kind of thing, compared to erosion. So that means whatever restoration we put on will be subject to very high loading forces. And there's a generalized moderate occlusal attrition. That's what we have at present. He also wanted the color of his teeth to be whiter, of A1 in appearance. So we have discussed treatment options. We always start as a preventive treatment only. Then we go down to the localized anterior wear management only, except posterior wear, of what we have discussed as Dahl concept many times. Restorative management of the maxillary teeth only is a conservative occlusal splint, but ultimately, patient wants something that's going to be highly aesthetic with minimal complications as he travels overseas like almost every month.
Right.
Yeah. We also discuss some of the restorative material options like full mouth composite, which is what I consider a short term in attrition cases, while that will be medium, potentially occasionally long-term for erosion cases, but attrition I would want as a very short-term due to the increased loading they have. To some direct with some strategic crowns, like on the first or second molars and the canines, or a full mouth of indirect restorative materials, which is what the patient wanted for the color consistency.
It's quite a aggressive form of treatment plan, isn't it?
Definitely not what would have recommend, but I mean ultimately, the patient have decided this treatment plan.
Yes, and able to get the ultimate aesthetic that this particular patient wanted. I guess sometimes we have no choice, but to provide certain level of treatments.
We can only be the advisors, but we can make the decision for the patient.
Yeah.
We also discuss due to his wants for minimal complication. We also discuss, the layered material have a better aesthetics, but there's also increased risk of porcelain chipping, considering the attrition was moderate in his case, or monolithic, not the high opaque zirconia material, but the monolithic, the slightly lower strength, the high translucency material, which is why he had picked, because it basically oversees a lot.
Yeah.
A composite mock-up was performed, and we have plain posterior onlays as conservative in this case.
Right.
But he pointed out to me, was saying, my teeth at the back are a bit yellow. They're not going to be like that in the final, isn't it? I said, Well, actually, we have planned some conservative onlays not covering the whole outer surface, the buccal surface. He said, "Oh, that's not really acceptable to me." So he's decided, ultimately he wants crowns on those teeth.
It's not every day you get a patient who wants posterior. Aesthetic perfection, is it?
No. So in this case, as he is more aesthetic driven, so we prep his anterior teeth first. In the lower anterior incisors, I try to keep it as the veneers. But obviously, I'm not comfortable with doing veneers in the canines. But these are monolithic zirconia, so I prep them to the depth of that 1 millimeter.
Right.
Yeah. Some may become a bit thinner, but my technician felt comfortable that the marginal fit would be still quite. Be good at the 1 millimeter. Yeah. And then we finish the posterior. So, for functional driven, we do posterior first.
Yes.
For aesthetic driven, well, I do anterior first.
Yes.
Yeah.
Very sensible.
Yeah. And then that's his finished result. Whenever I can, I try to have gold.
Yes.
On the 7s.
Yes.
On the 6s, but that's not very successful.
No. Beautiful case,
it's
Johnson.
It's pretty amazing for someone who did not accept a partial onlay with his teeth being yellow to accepting a 7 full gold crown. So that's great.
I suppose he doesn't have a Julia Roberts smile. If he has, then of course I won't be able to do the gold crowns on the 7.
But it goes to show that a lot of our patients are very reasonable minded when they see the reason why and what conserves and preserves the outcome. And there's always that dialogue. And I think it's a very nice scenario to actually wrap up when we are treating these cases. While we're on the topic of being non-carious tooth wear, still we have to respect that we have to address the patient's presenting complaint.
Yes.
But what we do need to highlight that this is a real issue that we have to integrate in our planning when it is present. And it is certainly something to inform the patient from the very beginning, because it carries with it a lot of our long-term maintenance and complications. But most of all, it's in the well-being of the dentition for the patient.
Absolutely. Now, ladies and gentlemen, it is coming up to the end towards our session. Guys, before we leave our audience for tonight, any final remarks?
I think the main remark I might have is that thank you for allowing us to share with you this evening all the cases that we've prepared for you. If there is one message that I think would be really good is sometimes when we deliver the information we want to give our patient, we are very good at labeling the facts and giving them ways. But something as simple as to just letting them go home with some tactics that either you formulate that is very direct and straightforward for them to follow, or to invite them to work out their own strategies, to work out any ways or things that they can do to change certain habits, would be very, very helpful to whatever the rehabilitation process is. And even though we may prescribe our splints, and even though we may get them to rinse with the bicarb wash, if there are further underlying issues such as mental health or social issues, and gastroenterology issue, they need to continue to follow that up where it's a whole team approach.
Yes. Johnson?
I think diagnosis and then getting the patient to have the ownership is very important, because these are complex procedures with increased complication rate compared to someone who doesn't have this habit. Is very important for them that after we restore, it's an ongoing maintenance. Many years down, we may have to replace them. And of course, treating erosion, where we all have done all composite cases because of the lower loading compared to attrition, where one of my patients would treat my composite like tofu. It's very important in what you're comfortable in treating and what you're comfortable in not treating. How about you, Ben?
For me, I think it is important for us to educate our patients and to pick and to select the right cases. It's not just in terms of selecting the right cases in terms of technical difficulty, because I think as a clinician of treating these cases, the technical execution of treatment tends to get easier over the years. But what's inconsistent sometimes is the patient's mindset. That's not something that you can just control. So therefore, say for me, in terms of patient selection, is work with reasonable people. If after that initial discussion with the patient, if you felt like you don't mind sitting down and having a beer with them, that's probably a good sign. If you felt that initially you can't even having a scientific, a rational discussion about the etiological factors, then you have no chance of explaining to them why something has failed when things do go wrong.
And I think it's important to highlight that that don't rush into things. I just want to make sure that we, after showcasing all these things, even though we did initially say that we need to diagnose, there is a time period.
But we finished like 20 rehabs in 2 hours, right?
That's right. And there are appointments to take, and and different consultation appointments to take at the beginning to allow sufficient time to really ensure that certain risk factors are controlled. And if in doubt, don't start your management. I think for those who had the streaming questions about, well, what happens if all these composites fail and everything fail? Well, that's a big alarm sign that there must be a lot of risk factors not addressed. So don't start. The preventative strategies may not replace loss to structure, but certainly can be implemented to prevent further loss. So if in doubt, don't start and just wait that few months more.
Yes. And always solve the underlying factors before you proceed to your definitive restorations. Well, I would like to thank you both for your time and wisdom throughout this evening. And also, of course, I would like to thank the audience for staying with us. And also, of course, to Noble Biocare for their sponsorship of this evening. Once again, ladies and gentlemen, thank you for your time. We had a wonderful time in this particular period of uncertainty. Please stay safe and keep well.